I think we have the blessing and honor of having Professor Palanivelu sir also joining us. Happy to have you, Professor Palanivelu sir.
Yes, hello, how are you?
Professor Palanivelu sir, are you with us?
Can you hear me?
Yes.
Hey, Simon, yeah.
Oh, hi.
Yeah, very nice. See you there.
Right.
It could be a super solution. Thank you.
So we are going to have a session, discussion on training and research on minimally invasive esophagectomy. Can I just check my panelists?
Yeah.
Mark Smithers.
Yeah, I'm here, Simon.
Is Omar Elvis here? And also Pramesh?
I'm here. Hello. Simon, have you got me?
Is Pramesh around?
Dr. Simon, I would look out for Pramesh. You please start the session.
Okay, all right. Okay, so I'm Simon Law, very honored to chair this session on training and research on minimally invasive esophagectomy. Now, on the panelist, we have Mr. Simon Dexter. I'm not sure if he is around yet. He is a consultant surgeon in the Leeds General Infirmary in the UK. He has been around, even to Hong Kong, trained at the Chinese University of Hong Kong, Tufts at Boston, and also NCCH in Tokyo. We have Professor Pramesh, who we're looking for at the moment. He's the Chief of Thoracic Surgery, Professor at the Tata Memorial Center in Mumbai. Dr. Mark Smithers, Professor and Discipline of Surgery, University of Queensland. He's also the Director in the Upper GI and Soft Tissue Unit in the Princess Alexandra Hospital. And last but not least, we have Dr. Omar Elvis from University of Pittsburgh Medical Center, of course, one of the biggest minimally invasive esophagectomy centers in the States. And of course, Dr. Palanivelu, who joined us, minimally invasive esophagectomist par excellence from India. And I'm very glad that all of us are with me to discuss on these issues on esophagectomy. So this is the
Simon, I'll be for some time. Then I'm next lecture. I have to go to Romania Hernia Society. I'll be part of this symposium. Then I'll leave it. Huh?
okay, no problem.
I don't want to. Oh, fine.
So we have about half an hour to discuss various topics on training and research. Maybe I'll just kick off on training first. And now one of the questions that we often ask is, how to train people doing minimally invasive esophagectomy. But actually, before we even talk about how to train, I would like to ask, who to train. Now, of course, it depends on which country you come from and where. Now, in a country whereby you have lots and lots of esophageal cancer and everybody is doing it, of course, there's no problem. But there are countries with moderate incidence or even a lower incidence country. To train someone doing minimally invasive esophagectomy and takes a long time. It's also a very complicated operation. So it may be something to say that, rather than taking all the general resident going through general surgery or thoracic surgery to go through esophagectomy, maybe it is not worth it because these guys in the future are not going to be specialists in doing esophagectomy. So should we be confining our training to really dedicated specialists who really want to spend the rest of their career doing their esophagus? Or should we be more general and treating, training everyone who is going through your residency? Maybe I can pose these questions to the panel. Maybe from Mark first. What's the situation in Australia?
Well, I think it's very easy. We're a low volume country, Simon. And so training in this operation occurs for people who are selected for training. We have a national group, the Australian New Zealand Gastroesophageal Surgeons Association, and we have a 2-year training fellowship. And even in that, those people who rotate amongst the training positions, a number of those will do obesity, a number will do benign surgery, but only a select few will end up doing esophagectomies when they finish. And those people will tend to be those who've nominated they want to do it, and they've been selected by the larger volume centres such as ours and some of the other centres in the United States. When I say large volume, you know, in my public and private practice and with my colleagues, that's about 40 cases a year, and that would not be seen as large volume in Asia, not by you, and certainly not in the US or other places. So we're very careful at looking at outcomes, at auditing outcomes, and our outcomes are as good as anywhere in the world, in spite of the smaller volume. So I think it's very easy. We have training registrars come through, and they might do part of the mobilisation in the abdomen, but they won't be doing the minimally invasive work. They will do fundoplications laparoscopically, but not esophagectomies. That's for the subspecialty training group.
So it's really the selected few who are sort of dedicated in their esophagus before getting to it. What about Omar in the States? What's the situation there?
Thank you, Simon. I really appreciate this opportunity to having me on the call. But our training here is pretty rigorous because most of the tracks to do cardiothoracic surgery either do a traditional track after 5 years of general surgery, and then they do a 2-year cardiothoracic. And typically, even those 2 years of training are more broad-based, but those residents who are training in those 2 years after 5 years of general surgery, they are selected to do advanced year of MIS training, which would involve specifically the oncology aspect of the esophagectomy. And then you have your traditional I6 programs where you have residents who are doing cardiothoracic training in 6 years. Even in those residents, when they finish, we recommend or encourage them to do an advanced year if they want to focus on MIE afterwards in their practices. So I agree with the panelists that this is a complex operation. There have many steps to it, and you have to master each step to be a master surgeon. So our philosophy has been, even in those I7 or CT residents who are finished their training and doing advanced fellowship, that we have a very specific approach to master each step of the operation. For example, in the first month, may say, okay, let's put the ports in, set the case up. Well, today you're going to do the gastric tube, the mobilization. Well, next week we need to do pyloroplasty, and then the chest port. So it's kind of broken down into steps of the operation until you master each step, and then you become your own efficient surgeon. So it definitely takes many years. The resident has to be dedicated to esophageal surgery. One of the benefits we have, at least in Pittsburgh, is that we have a very unique practice because we do a lot of benign work and malignant work. So we have the opportunity with a high volume of benign cases that the skill set's very similar. It's translatable from doing, let's say, a paraesophageal hernia to a redo fundoplication to a Nissen. Some of the steps are very similar to doing a esophagectomy. So that's been our experience. We do encourage that they spend extra years after their traditional training to do for esophagectomy.
I understand that in the States, the esophagus are being dealt with by thoracic surgeons. Am I right?
Correct. Yeah, that is true. Now, there are some programs where there's a combined approach. In some institutions, the general surgeons may do the abdominal portions and the thoracic surgeon may do the chest portion. But for the most part, most programs, the thoracic surgeons are doing the esophagectomy for esophageal cancer. But there's some discrepancies in some institutions where there's a combined approach.
Okay, because say for the say laparoscopic fundoplications, are they done by general surgeons or are they done by thoracics?
Yeah, I would say most of the foregut procedures are done by general surgeons in the States. There are some programs that also, some academic programs that also tackle the foregut procedures as thoracic surgeons. And thankfully, we're one of them in Pittsburgh. But I agree with you, majority of the foregut benign cases are done by general surgeons.
In Australia, Mark, it's different. Is that right? You have sort of OG junction or by OG surgeons rather than thoracic.
So we're all general surgeons, and some have had an exposure in thoracic surgery, but most of the exposure, I don't do any lung surgery. I've done some thoracic surgery in my training, as have a number of the esophageal surgeons, but we're all general surgeons trained in upper GI, and I do gastric cancer, all the benign upper GI surgery and esophageal surgery. And the thoracic surgeons have got plenty of work doing all their other cancer and other work. And so we work together if there's need to do so.
Pramesh, welcome. I can see you now. You've finally joined us. We were just discussing, who are the people that we should train to do esophagectomies if you're in a sort of moderate or even a low volume country, because not everyone is going to be good at it unless they spend years and years doing it. So a general surgery resident or a general thoracic resident who comes through, even if you teach them, they may not be, be able or, dedicate themselves to do it in the future. So what's the situation in India?
So in India, esophageal surgery is quite fragmented in the sense that a large part of it is done by gastrointestinal surgeons, some by general surgeons, and a few by thoracic surgeons. So the frame of having pure general thoracic fellowship or residency is just coming up in India. It's not been the rule. There are some centers where we have had thoracic surgery for several years and decades, but the default option has been so far that the majority of esophageal surgery is actually performed by gastrointestinal surgeons. And in a few centers like our own at Tata Memorial, we have the thoracic surgical unit treating it. So I don't think there are, you could be too dogmatic about who should do it. I've seen good general surgeons who had a serious interest in upper GI surgery doing extremely well at that. And I've seen a few who've trained to be thoracic surgeons, but really haven't had the exposure to esophageal surgery, not doing so well. So I think it comes down to a combination of what you're trained for, the areas that you're trained for, and your own interests and where you focus on. But I completely take your point about the need for centralization. Esophageal surgery is not for the low volume surgeon or for the low volume hospital. I think it's one of those areas where there's conclusive evidence now to suggest that they should be restricted to high volume surgeons, high volume teams, and high volume hospitals as well.
I remember a few years ago I was visiting Pittsburgh and with Lukitich there, and I was saying that, well, esophagectomy is not a operation for the residents. I don't think that went down very well with the residents. But anyway, I mean, that's the point that I want to make. If you want to be dedicated esophageal surgeon, then it really takes years to do that. Now, then we come to how do we train the surgeon. I think Omar has already mentioned something about breaking into different steps, taking the residents from junior to senior and go through each steps as a sort of program. Do you have that sort of program in Australia and Mark? How do you actually train? Then we come to
so in general surgical training, there's a lot of laparoscopic surgery, and as you know, most of us are a little bit overweight, and our culture are a little bit more prone to gastroesophageal reflux, and so there's a lot of upper GI laparoscopic surgery, anti-reflux surgery. So the surgeons that will work in our unit and that are interested in upper GI surgery will have done a lot of laparoscopic surgery by the time they finish their fellowship. We require a 2-year fellowship in upper GI, and actually if you're going to work in my unit, there'll be a 3rd year, probably overseas in another specialist unit, which is just reinforcing the need for this extra time and effort and training, particularly in the area of esophageal surgery. So the process then would be when they're working for us, they're working as a fellow, they're taken through the surgery, always with another consultant in the room. And although we haven't really broken it down as nicely as outlined by Omar. It's what taking them through the steps, taking over, showing them what to do at certain parts of the operation, and just guiding people through. And then when they finish, a number of the surgeons we have had fellows, they go back to units that have already got surgeons doing it. So we're always encouraged to work with somebody a little more senior when they're doing their first cases. I think there's some nice work looking at learning curves, suggesting the learning curve can be reduced if there's two surgeons doing the work, and therefore if there's a fellow or a junior consultant working with another surgeon as they're being proctored through their early consultancy, we see that as a benefit. And now that there are enough surgeons on the ground in Australia, that tends to be what happens. Whereas there was a period there when we were all in our learning curve. And I think that's a good time now that most of the young surgeons are proctored through their early experience as a junior consultant.
Do you think simulation or working on cadavers, that sort of thing help? Maybe Pramesh? You need to unmute yourself first.
Yeah. So yes, I do think things like simulation and working on a lap mentor, especially for minimal invasive esophageectomy, is a good option. It kind of gets them used to some level of hand-eye coordination and getting them to work on the optics of it. And I agree completely with what Mark said. Breaking it up into smaller bits of the surgery, we found certainly helps. We have a large number of fellows and residents training with us at any given point of time. And even though we are a fairly high volume center, when it actually comes down to doing the surgery, we find that giving them small bits to start with and then going on to doing either the entire thoracic part or then the entire abdominal part really works very well. And then they're finally ready to get to the full procedure. So they may not have the full satisfaction of doing the entire surgery by themselves in the first few procedures that they do. But overall, I think learning it bit by bit does help a lot in their overall training process. So what we've learned from the robot is actually that by just sitting on the dual console, watching the primary surgeon operate gives a very good opportunity to trainees to learn the steps of doing an esophagectomy. And again, even with regular minimally invasive thoracolaparoscopic esophagectomy, trainees seem to learn much faster than with open surgery, primarily because it's all open, it's magnified. You see it on a big monitor instead of trying to peer over the primary or the secondary surgeon's shoulders. So I think there are plenty of benefits to this, and at least I am a big fan of trainees using the simulator or the lap mentor to start things off.
But I think people who are starting to do esophagectomy, I mean, they should not be beginners in laparoscopic or thoracoscopic surgery. I mean, they should be quite experienced already. Otherwise, they wouldn't be able to do esophagectomy. So, I find it using, say, the LEPSIM or whatever, it's not really that helpful because they've got the skills already. It's mainly the anatomy which matters. And I think, when you start off with having a cadaveric model would be a very useful thing to start off with anyway. Same with gastrectomies. But I'm quite sure that the cadaveric model won't be available everywhere so easily. Omar, is it available in the States, for teaching people to use cadaveric models?
Yeah, that's a great point. I would suggest regarding simulators for complex surgeries. I agree with you, Simon, that for advanced procedures you have to be well trained and well beyond that phase of simulation. And also you have to have protected time. A lot of times, the residents may not be motivated to be on the simulator. They have to have protected time for that. The most of our training that we do occurs in the operating room, because you have so many years of training. And for example, we don't have the cadaveric stuff available at Pittsburgh. I can't comment on some institutions that may have it or not. But the two resident model with a two faculty or fellow model, I think, is a very good model. because you can work together with the fellow on the side of the surgeon and kind of take him through the steps of the operation with an experienced assistant on the other side who's helping you with the process. I think that has worked well. Occasionally with tough cases or tough MIs and obese patients, we may have two faculty working together, but then some parts of the case, you know, I will give it to the fellow when the other faculty is assisting me in the case. So that's been actually very helpful, and I agree with Mark on that. The other things that we have incorporated or starting to incorporate a little bit now is actually videos. We would video a piece of the operation that the fellow is doing, and then somehow sit down with them, you know, at a later time and critique their movement and show them our movement when a surgeon who's mastered the skill and how that's different. Because sometimes in the heat of the battle, see your deficiencies or inadequacies, but you reflect on them later on, you'll definitely get a much better idea which you have to work on. Typically, it's the left hand. I think the resident fellows don't work the left hand well enough to assist themselves in the operation. So a lot of our learnings in the OR because of the volume, and a lot of the learnings, I think, for advanced fellows. No, we don't have a cadaveric model there yet, but that's a good idea. I think we should look into that.
Well, welcome, Mr. Dexter. Nice to see you, Hara Simon. You can hear us?
Apologies. I've been trying to get out of theatre for the last 20 minutes. I've left one of my lads do a complex case.
Don't worry.
Afraid, but,
now that you're here, maybe we can give you a difficult question. is the question of how do you assess competency? So we've been asking the panel, how do you treat people? I mean, train residents, and they've given us some ideas. But at the end of the day, you have to assess competency. So how do you do that in the UK? To say that someone is good enough to do a esophageectomy?
Yeah, so competency is assessed in various ways, but actually technical competence is something that isn't formally assessed. It's not, people will turn up with their, logbooks of what they've done, and there'll be a measure of what cases they've observed, done under supervision, and they're expected to complete to a certain level. But in fact, there isn't a formal competency assessment. However, these guys, particularly doing this kind of complex esophageal surgery, are obviously senior trainees, and they work closely with their clinical supervisors who will, have to sign them off and, having trained them. I think the difficulty, though, is, however it turns out, it is a subjective assessment. You may receive someone who's towards the end of the training that you don't feel are necessarily competent enough, and the difficulty is what you do with those. Are these people who are always going to struggle to have safe, good quality outcomes, or are they people who simply need some more time and training? And that's always a discussion point. Although training is limited, you can't keep turning people out into training positions when they're towards the end of their training. So it is a difficult issue, and I think you can formally assess technical competency, with different elements of the procedure, if you like, or different of doing perhaps laparoscopic or robotic surgery, albeit robotics much better geared up towards technical assessment. But assessing someone on how they perform a whole complicated procedure is it's a really tough thing to achieve. So I suppose there has to be a degree of subjectivity in that.
I think recently I'm involved in a project proposed by Professor Rosman from the Netherlands. Again, exactly looking at the competency assessment tool for people who are doing an Ivor Lewis minimally invasive esophageectomy. I think it's a very good idea. What they did was they group around the international group of experts and give them a Delphi survey on what are the key steps of doing a esophageectomy, and then break them down to many, many steps. And then for each steps, they will have a competency assessment tool to grade them. And then they will give us videos, a full-length video for people who have done esophagectomy, and ask us to grade the competency on each step. And I think it's actually developing into quite a good tool, because these are key steps that are agreed by experienced surgeons. They are graded with pretty objective way of looking at things, and at the end of the day, you can assess competency on different facets of doing the operation. And I think this may be one way to get about assessing competency. In Japan, the Japan Esophageal Society is accrediting expert esophagectomists. So if you are a surgeon who wants to be accredited, you send your full-length video to a group of experts under the JES, and they would assess you and to see whether you are accredited to be a competent esophagectomist, if you like. But that's a voluntary thing, in Japan. And I think all these ways are very good. And I think Omar made a very good point that nowadays with the videos, that is a very good thing that we can look at after the operation at leisure, and you can actually break down the different parts and to feedback to your residents and train them and assess for competency. I think maybe that's the way to go. Now we are supposed to talk about training and research, so we've gone through half of our time already. Maybe we should spend some time on research. So the first question I want to ask the panel is that there have been studies comparing MIE with open esophagectomy. Do you think 2020, 2021, we still need to ask that question, whether MIE is better than open or vice versa? Maybe Mark first.
Well, it is interesting, isn't it, when there are a couple of randomized trials that show benefits, and then in the Netherlands they looked at what happened when it went into the general community and it didn't show the same benefits where the surgery was done in specialist centres, which is where the randomized trials were occurring. So the question is, would another randomized trial of open versus minimally invasive or hybrid done in specialist centres, which is where it's likely to be done, add to the literature? Personally, I'd really like to do an open versus the hybrid that I have done lots of, which is the thoracoscopic in the chest and the open abdomen. Now we've moved across to the laparoscopic abdomen. In an obese patient, it's actually nicer than doing an open abdomen. And it would have been, and back in the day when we first started doing this, we wanted to prove that what we were doing was the right thing. And in non-randomized ways and with propensity scoring and case controls, we never really could. And the only thing that really we found a difference with was with pain, and that's been shown in two randomized trials, and constipation, and that's probably because of the pain relief that people had when they had their thoracus open surgery. So that's a long-winded answer to say I don't think we're going to gain that much more by doing that, because it's all about what's the endpoint we're looking for. And I think operative mortality it's all being done in the specialist centres, it should be, and so that shouldn't have an impact on operative mortality. It shouldn't have an impact on cancer, although, Christoph Marriott's study is a little signal there that people have looked at, and I don't understand that at all, that signal, but that's to look at. And the bottom line tends to be respiratory, and we always thought that we'd get patients back to work and back to normal activity quicker. We haven't sort of proven that. So it's all about what the endpoints would be that we want to look at as well, Simon. So open versus minimally invasive, I know there's a few more trials that are going to be reported, and we always finish our talks by saying we need a randomized controlled trial. Now everyone's getting robots. Are there going to be any randomized trials of robot versus minimally invasive? I don't think so. So that's a long-winded answer, probably not.
I think I agree with you. I mean, results from trials, of course, always better than, the community. So one has to be very careful about, translating the results from randomized controlled trial to the general, community outside. And I agree with you perfectly that the endpoints are really very difficult to define. And honestly, MI is here to stay, because so many people now are doing it. It's very difficult to say, it's not useful. The more people asking the question is, like you say, total MIE versus hybrid versus robot. What do you think, Omar?
And I mean, those are a great point. I mean, I think the last 20 years, if you look at the percentages, very few people were doing MIE early 2000. And I would say now maybe 50% of trainees potentially who are done advanced training, maybe doing some type of MIE procedure, whether it's hybrid or completely MIE. So your training definitely impacts, how you're going to do your operation. I'm not quite sure if robotics or MIE or open, if you look at head-on-head, would have any different outcomes than high-volume centers, academic centers, comparing them one to the other. Because as you mentioned, the endpoints are very similar, right? The most important thing, I think, what we should be teaching our fellows and graduates is that it has to be an oncologic sound operation. So our philosophy is that if we do robotic or minimally invasive, we do the same operation as we do in open. There's no shortcuts. There's no cutting corners. If you can master that step, minimally invasive, whether laparoscopic, robotic, or VATS, you should convert to open. So that's been what our philosophy has been. I do have to say that doing a robotic or minimally invasive laparoscopic VATS, there's plenty of data no matter where you look at in terms of length of stay, perioperative pain, convalescence. All that's been well proven, with various surgery that doing minimally invasive is much better for the patient. As long as you can maintain the oncologic principles. And I think, MIE will be here to stay and robotic, and I think it will flourish in the next 20 years also.
The robot, do you think it has advantage over traditional VATS? Simon, you have any experience with robotics?
Yeah, I think it's the whole issue is an interesting question. And I think that ties into what outcome measures are we looking at. It's, a lot of the outcome measures we've looked for are fairly easy things you'd expect to find a difference. But in reality, does a couple of days of hospital stay make a huge amount of difference to overall cost, for example? So the longer term issues of patient-reported outcomes need more focus of attention. And I think the other thing, and it'll come back to your question, is about robotics, is these are long, difficult, arduous operations, and those of us who spent a lifetime doing minimally invasive surgery are starting to creak a bit. And I think one of the advantages, even if there's no other advantage compared with a standard minimally invasive procedure, one of the potential advantages of robotics is surgeon comfort, longevity, and focus. And I think it's a sort of overlooked outcome measure, which is important when you're doing these cases.
Ramesh, any robots at Tata Memorial? Need to unmute again.
Yeah, so we do have a robotic esophagectomy program at Tata Memorial, but I must say I'm a little underwhelmed by the outcomes that we've had with the robot as compared to thoracolaparoscopic esophagectomy. Where it possibly has an edge over thoracolaparoscopic esophagectomy is the learning curve it takes for someone to transition from open esophagectomy to minimal invasive. I suspect it will be a little quicker with the robot. But when you've got someone who's experienced with thoracolaparoscopy and then transitions on to a robot, I find the benefits to be very marginal. And let's not forget for a moment here the hugely different costs associated with using the robot over conventional thoracolaparoscopy. So the transition from open to thoracolaparoscopy was one step ahead. The cost difference wasn't much, which made it far more acceptable. Whereas the cost difference between a thoracolaparoscopy and a robot is much more. And to be honest, I don't see any significant differences with a robot over a good thoracolaparoscopic surgeon.
I agree. I think the point about the appropriate endpoint, if we want to do a trial, is very important. Just like what Omar said, or Simon says, a couple of days of hospital, a little bit of pain relief, it probably doesn't matter. But there is recently a trial I think is very clever, is the REVAGE trial. I'm not sure whether you're aware of that. It's robotic versus VATS, but the primary endpoint is successful left recurrent laryngeal nerve lymph node dissection, which I think is actually a very clever endpoint, because that's actually my personal view too. I think maybe it's less relevant in Western countries, but in Asia, because we do a lot of superior mediastinal dissection, and the most difficult area is the left recurrent nerve dissection. And the endpoint of this particular study is to look at successful left recurrent laryngeal nerve lymph node dissection, evidenced by nerve palsy rate, as well as successful lymph node harvest along the left recurrent laryngeal nerve. So this is, I think, a very clever outcome, because I really don't think the other things you're going to see much difference when you're doing comparing VATS with robot. And the advantage that I see with the robot is that with the dexterity around the left paratracheal area, that just may be one thing that you may find a difference. I think the trial is still recruiting. I will be very interested to see what the outcome is. Well, the next thing I'm interested in is, say, randomized control trial. We always talk about randomized control trial. If you guys want to have a randomized control trial with MIE, what would be your top priority, you think? Anything? Mark, you want to design a randomized control trial, what would you do?
I've actually been thinking about this, and I'm at a little bit of a loss. I've sort of talked myself out of doing anything that's open or hybrid versus. So it's going to be some component of what we're doing, when then it'll be looking at the endpoints such as return to activity. But I think what you just outlined is that there are certain aspects of, say, a robot where it does have an advantage, and it's being more facile. So maybe an anastomotic, and particularly for an Ivor Lewis, when you look at the outcomes in the big US studies showing a high leak rates, return to theatre rates in between 2007, 2011, when everybody's just starting, the anastomotic leak rate has got better as people have improved and got used to doing it. It may well be that those leak rates would be less for those people who are facile with the robot being able to do an anastomosis. So I think looking at the robot as part of an operation is probably the future. But how do you fit that into a random? I'm not sure. Simon, you sent me a little text about this, and I've actually been thinking about it all day, and I still haven't come up with a great answer. I'm sorry.
It's okay. Any ideas from the other panelists? If you want a trial, starting tomorrow, what would you study?
I agree with all of you, and I think the area of study would be a comparison between total MIE versus total robotics. We should focus on. A lot of the trainees now are doing one or the other. Even in our institutions, we have 2 faculty who do robotic MIE, and you have 2 or 3 other do MIE. So I think it'd be nice to look at, like, for me to do robotic now, because my training has been so advanced in MIS that for me to translate to robot now would be very difficult, and because of my skill set the last 15 years. But somebody coming out, training now who's doing robotic versus MIE, it'd be nice to see, how their outcomes are, because that's the future, in my opinion, of minimally invasive esophageal cancer surgery. Going back to that point, there's always opportunities to do other trials. And right now in Pittsburgh, we're doing, and Simon, you did this many years ago, pyloroplasty versus pyloromyotomy. And we're trying to look at that minimally invasive, one or the other, and see if lac or pyloric drainage is necessary for MIE or not. So we kind of come back full circle. I think the focus should be more on advanced training of robotic versus MI moving forward.
Okay. Simon?
Yeah, it's a good question, and I think you've got to look at where the problems in esophageal surgery. And I guess an area we're increasingly seeing, you've probably got a lot more experience than us, is salvage surgery in people who've had curative or definitive chemoradiotherapy. You've got local recurrence, and I guess the problem with that is when you go in and do a radical resection, there's the potential for quite a high morbidity in that subgroup of patients. So whether there's a role for a more modified resection, perhaps without the extended lymphadenectomies in that group, in order to try and reduce morbidity and then look at overall outcomes. I don't know. That would be one of the things that strikes me as a problem area.
Okay. Ramesh?
So I must admit I'm a lot more circumspect about the benefits of the robot, but what I'd really like to see is some concrete data to support the belief that the robot could actually be superior to MI, to conventional MI. And I would echo what Mark said about finding a meaningful endpoint. So to me, if you had to look at one composite endpoint, it would be overall major complications perioperatively between the two procedures. And if that showed that the robot was superior, I'm happy to change my mind. But I think that's data that needs to be shown and proven now.
Okay. Well, I think, thank you everyone, the panelists especially. I think there are lots of insights for us to look at. It's just our time is up. So just want to thank you all for joining me, and thank you for the organizer and the conference for inviting us. I thoroughly enjoy this half an hour, and I hope you have done so as well. Okay, thank you very much. Thank you for joining us.
Thank you, Simon. We have
on behalf of the
to speak to you. Yeah.
On behalf of the organizing committee, I would like to thank Simon Law. Great to see you, Simon, after a long time. Last time we were together.
Well, we hope to see each other face to face sometime when this COVID thing is gone. All right. Thank you.
Thank you, Professor Simon, Professor Ramais, Omar, Professor Dexter, Professor Mark Smithers, Professor Pramesh, and it's been a pleasure hosting all of you. Bye-bye. We look forward to seeing you soon in person in one of the platforms. Bye, everyone.
Omar, Pramesh, some engaging panel discussion. Very grateful for your time.